Today we have a webinar scheduled on one of the very important topics in orthopedics, and that is achieving orthodesis. Especially, we'll be discussing the topic on knee orthodesis, ankle orthodesis, and the wrist orthodesis. We have an eminent faculty list with us today. And to begin with, I would like to invite Dr. Rajendra Abhyankar to address all of us. Dr.
Good
Abhyankar.
morning, everybody. It's my pleasure in announcing the 2023 webinars of Maharashtra Orthopaedic Association. We have started again the good work started by Dr. Gadegone sir last year, Young Surgeons Forum and Veteran Surgeons Forum. I appreciate the work put in by Dr. Kotadia sir and Dr. RM CHANDAK sir and OrthoTV. I request Dr. RM CHANDAK to start the webinar. Thank you.
Thank you very much, sir. And myself, Dr. RM CHANDAK and Dr. Harjot will be moderating this session. And to begin with, we invite Dr. Tanna sir for his talk on achieving orthodesis at knee. Welcome, Dr. Tanna sir.
Thank you. Can you see my slide?
Yes, sir, we can see and hear you also.
Okay, I'm talking on the knee fusion. Now, a case like this was originally a small fracture proximal tibia, which ended up with the external fixation, which I'll come, infected. And so then I had to do the fusion for that because they were not billing for a total knee after this. Now, how do you proceed to do the knee fusion? Now, here is the first and the foremost. I always use a TKR instrument to do the distal femur cut and the distal tibia cut. And minimum tibia and minimum femur cut is done, unlike whatever we do for TKR. It is a minimum cut in order to get the red cancellous bone on both the sides. So this is done with the TKR instrument so that your alignment and everything can be perfectly meshed. So once you got the good alignment, straightening it out, now this is how we start reaming the femur. First ream femur from proximally and then ream proximal from distally and let these two cavities meet. Once the femur has been reamed, then you start reaming the tibia. Once you ream the tibia and ream the femur, now once you ream the femur and ream the tibia, you can start putting the nail in the femur. Put the nail in the femur, bend the knee, and try to get this opening in the tibia. And then with this small gap which is created, you will be able to go there in the tibia. Once you go in the tibia and now everything has been done, and check the axis again. Once you check the axis, now you have a time to really get the knee going. So here it is. Now this is the nail which is going inside in the tibia. And now you got to compress because this is the cancellous bone which you can compress, and then unless you compress, this is cancellous bone is not going to heal up. So with any of the devices, you do the Charlie device or you do this external fixation, compress the articular surface. Having now compressed the articular surface, these are the two locking screws which are provided, so in which you lock the plate. And there are other two locking screws here and here. Now, you lock the nail in compression, remove the compression anymore now. You don't need it. And this is the end of the surgery. The femur, the thick Indian tibia femur nail for fusion is, this is the thick femur, thin tibia, because tibia cannot be more than 9 millimeters, while the femur can be up to 11, 12 millimeters. And these are the two holes on between, so that you are going to have a small curve of the femur in order to do. This is the additional holes near the knee joint. So once this has been done, you will be able to get the knee fusion done in a perfectly straight position or minimally flexed position. Generally, a patella raw surfaces you can keep it out and put in a screw there if you desire, but that is not necessarily all the time if there is a good bone here. Here was the same case, a small fracture here. I don't know why the surgeon decided to do an external fixation. In this external fixation, the pin track got infected, and then ultimately this is how it ended up
moving.
Yeah.
Slides are not moving. You are changing the slides now, but we are not able to see new slide.
So it is stuck up on the nail slide. That is slide number 26 we are seeing.
Which slide you saw last?
So it is on your slide number, it is 26 and 7. Those figures are there on the bottom.
No.
So where there is the graphical representation of...
You saw this slide or no?
So
No.
we are still not able to see the changes.
Have you got?
So I'll have to, I think you'll have to stop share and share again, sir.
Yeah, I understand.
Yeah.
Just few minutes, sir.
Yeah. Welcome, Rajiv Shah, sir. And Dr. Hemant Patankar, welcome for this webinar meet.
Good morning, Tanna sir.
Good morning, Rajiv. How are you? Just few seconds, I'm coming back.
Yes, sir. No, absolutely no problem. Dr. Kotharia, sir, if you are using the same nail, the long nail femur to tibia?
Yeah, I'm using the same nail, and
So,
I usually use it for resection arthrodesis in that bone tumors.
Okay. And sir spoke about a more proximal, thicker for femur and distally thin nail.
Thinner nail.
Yeah, we are able to see, sir, now.
Now you can see.
Yeah.
This was the slide we saw last.
You see.
Slide number 6. Slide number 6.
Slide number
This is the nail.
Yeah.
And as I mentioned to you, thick femur nail, thinner tibia nail with the holes nearby. And here was the case. Proximal tibia, small proximal tibia. Surgeon decided to do it with the external fixation and then the pin track which went inside into the joint, and ultimately this ended up into the knee fusion. Now, this is the one which I did the knee fusion. So I had to do the small osteotomy here in order to get the knee straight. This is how it was ultimately done. And then you can see over the time, this everything fused up. 4 years walking, and then there was a stress riser here. And after the knee was fused, you can see the nail, patient had a fall. So you had this fractured proximal tibia, and also the nail broke here. So this is the time again I went through, I removed the nail in pieces, in 3 pieces. I removed the nail and reintroduced the nail with that. And ultimately the thing went on to be very well. This is the another patient, marked deformity of the knee joint, and also at the tibia here, and the femur here. Now there was no, this is also the old infection, multiple surgeries. So decided to do the knee fusion. Now here, I went ahead. You can see there is a malunion here, flexion deformity. So ultimately, the way to go about this, you have to break here, get them straight, and the same way, ream above, ream below, and then you can get the knee into the straight position. And this is how it is ultimately boils down to a straight knee. And then you can see that ultimately, finally, the whole thing is held up. And you can see here, this was the bump which was there posteriorly. So everything ultimately heals up in due course of time. And that is the one after the removal of the nail. Now here was the other case, 40-year-old compound fracture, post-surgery, no sinus, knee stiff. Now you can see here knee stiff and still you go ahead. So I went ahead and I did the fusion. I did the knee, big knee. But since there was a big gap here, as you can see, there was a big gap here. Ultimately, I couldn't, the knee did not fuse. So it broke down. Once it broke down again, I took it out. All those, then the big nail was taken out. Massive bone graft was put again. Another nail was put in. And then another nail, and ultimately the fusion happened complete. So this is the one where there is a instability because of the bone block. That's the reason this does not heal up. Now this is what is an imported joint which is there, which you can put it here first and do it, the fusion there. This is what was available in India at once. I had asked for it, but ultimately they have abandoned it because there is no demand for this. And this is what it happened. Now you can see here, this broke down. This broke down, this broke down, this broke down. So I felt that the knee fusion which is done, after the knee fuses, the nail and the knee fused knee, coefficient of friction is different. So probably you should take out the hardware as soon as the knee is completely fused. Otherwise you will face these issues. And if it is instability like this, I feel that the knee fused, this is not going to fuse up because this is a thinner nail which becomes, and then if you are going to have this instability, probably the side plate will be very useful. After the if the bone needs adjuvant plate, you go ahead and do an adjuvant plate. Now here, this is approved TB on 2-month anti-TB offered TKR, money constraint and past bad TKR experience in the family. They chose fusion. So this is how the knee was, and I had to fuse it. So with this experience, with this bone gap which was there, missing, you go ahead and fuse it. So I put a nail as I was doing, and I will put an adjuvant plate, and all these things which were there were grafted. I'll come to that. From there, you can get a graft only locally. And this thing, ultimately, you can see 4 months time, she walks about, moves about. And actually, with this knee fusion with the nail and a plate, they can start walking about partial weight bearing almost from day 2, 3, 4, whenever they can manage. Now, here is an osteoclastoma. Huge, big osteoclastoma, which needed a fusion. Because I think at that time, the knee joint was not really possible. So this is an osteoclastoma. Decided to fuse it, excise the full complete osteoclastoma, and put in this fibula in the gap, in the tibia, put in this fibula, put in the nail, put in the patella, also with raw, and put in the screws there in the patella. And you can see this was the fibula which was put. And over a year, everything held up very well. So in this sort of a situation, your fibula was very useful for this tibia excision. As you can see, this is the tibia which is excised. There's the reason the fibula which is there. And probably today, I may also do an adjuvant plate, because if there is a big gap here, this may not heal up. Probably the fibula worked as a second implant, and this ultimately held up very well. This was the bone which had to be excised completely. And as you can see here, ultimately, this bone is missing, but still ultimately it held up beautifully. Now this was the femur, TKR, THR which was done, this femur which was malunited, and you can see this completely unstable knee joint. Now this is the one which was to be done. I offered them a TKR, but they refused. Having undergone many surgeries, they refused this, and ultimately I had to do the fusion. As you can see, the bone here, the knee replacement. So I chose to do a double plating. So first you do the plate, and all this bone anteriorly, you need to remove it in order to get a raw surfaces, and you can, all that bone graft, you can put it around. So all this bone is also is not useful for the fusion, because this is where if you're going to put a lateral plate, this is how you will have to put in. So you will have to cut out the bone here and get the surfaces straight. So all this bone is also not really required. So all this can be removed, and all this can be used as a bone graft, even in a nailing and in a plating. So here I removed that bone with the oscillating saw and went ahead and did it with the double plating. With double plating and a compression screw here, as you can see in such a badly deformed, the compression screw here, patella was fixed after raw surfaces, patella was fixed, the knee was compressed, and this is the one which ultimately went to give up. In conclusion, nailing is a safer way for knee fusion. Indian price nails are dependable. Only thing, they are not available all the time when you ask for. So you'll have to really plan it out. And some of those people make this Indian knee fusion. You can do according to your size which you require. At least keep 2 of them, minimum 2 of them ready. Generally, I end up into a 9mm femur and 9mm tibia and the 11mm femur, because most of the time you will be able to do that. Thank you very much. If any questions, please let me know.
So do you ream tibia or only ream femur?
Sorry?
Do you ream tibia also or only ream femur?
No, I have, in my talk, I mentioned that I ream tibia and the femur separately.
Okay.
Thank you very much, sir, for putting a lot of experiences on this. My question is, we aim at absolute stability in orthodesis, achieving orthodesis, and that is what a double plate
is a cancellous bone. So it has to heal up with compression. So absolute stability is absolutely necessary. And that's the reason, as I said, a nail and two locking screws near the knee. So that is the design of the nail, which I had done it long back, so that you can get an absolute stability. Today, probably, I will add up a plate, side plate onto the nail in order to be overkill, but I feel that is very useful.
Thank you.
Sir, you said there is a different diameter of the nails. So what diameter of the femur and what diameter of the tibia, whether you judge it pre-operatively or it's the same common to every resection arthrosis or arthrosis?
Sorry, can you repeat?
What is the, you said there is a difference of diameter of the femur and the tibial side of the nail. So whether you do it pre-operatively or it's a custom made nail or the nails are available with the same diameter?
See, the nails I had designed for the knee fusion, they are available in this diameter.
Femur 11mm?
Tibia 9mm.
9mm. Okay.
And a small bend at the knee joint.
Okay. Okay.
And those 2 screws were near the joint in order to get the stability which is increased. So it is not only the locking at 2 ends, femur and tibia end, but also there is a 2 screws, minimum 1 screw or 2 screws nearer the joint, upper and below.
So whether that bend which is a little bit near the knee, whether it gives a lot of stresses on the locking screw and the tibia, whether the nail got broke, whether it is because of the stress riser there?
Honestly, Pradeep, I have not been able to comment on that. But
Okay.
I felt that all the nails broke. 1 nail broke because of the instability, and another 2 nails broke after the fracture had completely healed up 4 years and 5 years after.
Okay, sir. Okay. Okay. Thank you, sir.
Could it be because of a long lever arm, which
Also, I think it is a long lever arm. And that's the reason nowadays I recommend that we should remove the nail once the radiological fusion and the patient comfort is established.
Okay.
Because only other thing is, these broken nails are very, very exciting to remove.
Yeah.
Total knee. Sorry, in a tibio femur knee. And I tell you why. Because all the reamers which are available, they do not go right up to the tibia. It will go maximum in the knee joint, but it will not go up to the tibia. So if that fracture which has occurred at the upper end of the tibia, it is a very difficult job to take it out. So I had made separate long extractors, and reamer I couldn't really, there are no extra reamers are available. But fortunately, with the long extractor, I could ream out with the extractor itself up to the upper end of the tibia, and then I could take out that nail.
No,
Because in that the knee was fused. So even from the non-union side, I didn't want to do it. Once I did this, once I could take out the nail, now it was very simple for me to change the big nail. Another one.
Yes.
The supplement plate site is laterally or anterior?
I think if you are putting only the plate, then it has to be anterior and lateral. If you are putting an adjuvant plate, then you can put it anywhere, either anterior or lateral. I put it mainly lateral.
So for compression, you use fixator devices?
Either a fixator device or any of those devices, external fixator device or a CHANDAK compression device, or if in case you want to do it on a DCP holes, but I do not trust those DCP holes which have been done in India. So I generally use a compression device, mainly the external fixator device.
Thank you, sir.
Okay.
Okay, sir. Thank you.
Thank you.
So you have any experience with isolated plate or isolated fixator used for knee arthrodesis, and secondly for failed TKR, have you done arthrodesis?
Failed TKR, generally we do the repeat TKR because those failed TKR have been infected and then we have to redo it. Only once I have done that fusion, but I couldn't really find that case.
Okay. And the amount of bone loss in a failed TKR is also voluminous.
Quite a lot because you have done the tibia. So that's the reason I choose to do the revision in that rather than the fusion. Because even if you do the fusion, you will end up with quite a decent amount of shortening. So that is the reason why in a failed TKR, the choice of surgery is a revision knee. Because you will end up with about 1.5 inch of 1.5 to 2 inches of shortening, which ultimately some Alizarov are going to elongate it. Because now there is no question of fusion and all. There is no question of a knee stiffness and all in this. So then ultimately theoretically you fuse it and then ask the Alizarov to extend it. So I think majority of the people choose a knee joint replacement. Only thing is the cost is the constraint. For those who have been able to get a primary knee, generally they can afford the revision.
Thank you very much, sir. For the viewers, if there are any questions, you can put it onto the chat box. We'll be taking those questions. With this, I think we'll invite, sir, can you just unshare the screen?
Yeah.
Thank you very much.
Thank you, friend.
Thank you so much. After the knee orthodesis, we invite Dr. Rajiv Shah, sir, for his talk on achieving ankle and subtalar fusion with the nailing procedure, the TTC nail. Welcome, Rajiv Shah, sir.
Sure.
We're all eager to listen to you. Most welcome.
Thank you. So thank you very much and very good morning for inviting me here. I hope I'm audible and my screen is visible.
You're audible. Yes. You'll have to share screen. You have to share.
Oh, I did not.
Good morning and welcome, Dr. Pankaj Jindal. Welcome.
I think now my screen
we are seeing this screen,
must be visible.
Yeah, screen is visible.
So good morning again. So when we talk about ankle arthrodesis, it could be arthroscopic ankle arthrodesis, which is done with the help of screws, or it could be an open ankle arthrodesis, can be done with the only screws plus plate, only plate, knee, or X-Fix and Elizaro apparatus. I'm going to talk about indications of ankle arthrodesis with nail. Trauma, either fresh or neglected, post-traumatic arthritis, various deformities, arthritis, or ankle arthritis with stiff subtalar joint, instability, infection, neuropathy, and tumors. These are the indications for ankle fusion with assistance of the nail. And it could be antegrade with 2 incisions, one at the knee, one at the ankle. And ankle incision, you're going with tibialis anterior medially and extensor hallucis longus and neurovascular bundle laterally. Putting a guide wire like you do for knee tibia nailing and reaming. And at the level of the ankle, you have to do distraction of the ankle, preparation of the ankle joint, and nailing and locking. So this is how antegrade nailing works. So far as retrograde nailing is concerned, it is a very common one where your patient is positioned supine with a bump under ankle and some degree of internal rotation is required. Your incision is marked at a lateral transfibular approach with running from base of 4th metatarsal to fibula tip to 10 centimeters proximally. This is the incision. And you do fibular osteotomy 2.5 centimeter above the tip of the fibula, starting proximal lateral, going distal medial. Ankle distraction is to be done. That is followed by preparation of the ankle joint by removal of the cartilage of the ankle joint. You identify the subtalar joint and start distracting the subtalar joint. Once you have distracted the subtalar joint, you remove the cartilage of the subtalar joint, and then you do lavage of ankle and subtalar joint, which is followed by drilling of the articular surfaces and feathering of the articular surfaces with an osteotome. Once the joint preparation ends, you temporarily fix the joint with a K-wire with the position of fusion of ankle being 0 to 5 degree valgus, neutral dorsiflexion, plantarflexion, mild external rotation, and talus is to be pushed posteriorly. The position of fusion for subtalar joint is 0 to 5 degree of the valgus. And you centralize the entry of your nail in AP and lateral view like shown here with the use of guide wires. And this is how your nail entry site is marked. You push in guide wire, do reaming, pass a nail, check under image, and do your locking. The nail which I use is one which is designed by me. It's a straight nail and with this kind of oblong holes, and there is a nut put in inside the nail which gives ankle as well as subtalar joint compression. The screw chronology is typical. The first 2 screws are above ankle screw. The next screw is into the talus, and then with the nut you do ankle compression. The next screw is a transverse screw in the calcaneus, and then you follow the subtalar compression with the nut. The last screw is posterior-anterior calcaneus screw, and you could think of pushing an optional freehand screw. The fibula is sliced out into half. Half medial part is used as a graft. The lateral part is put back to act as a live plate with 1 screw in talus, 1 screw in tibia, like shown here. So this is how you do retrograde nailing and do a closure over a drain. Some important cases I just want to share with you. Case of acute trauma, you may be obliged to do such kind of nailing. A 29 years old male with bilateral comminuted pilon, talus, and calcaneus. This is the X-ray on the left. This is the X-ray on the right. Obviously, there was no other option but to go in for bilateral tibiotalo-calcaneal fusion assisted with the nail. And this is the gait of this patient. Neglect trauma. A 24-year-old male had a neglected pilon fracture. It was now 6 weeks with such shattered pilon, which was neglected. The answer was antegrade nailing and ankle fusion with antegrade nailing. Neglect plus infected trauma. A female of 36 had a railway accident in 2019 and had a crush injury with compound fracture dislocation of talus. After multiple serial surgeries like debridement, external fixator, plastic reconstruction, it was at the end of 1 year that she was treated with TTC nailing with antibiotic beads, which was the surgery number 6. At 18 months, there was infection, non-union, shortening, ring fixator, and Bijlani amputation was refused by this young patient. It was at this juncture she was referred to us for further management. In stage 1, implant extraction and debridement was done. Antibiotic impregnated nail was prepared and it was pushed inside, and cement spacers were pushed into the defect. Post-operative antibiotics were given at the end of 8 weeks. There was no active discharge. Serology was normal. This was the clinical look. Sinus has closed. And in stage 2, we went in and did implant extraction and lavage, used revision TTC nailing with antibiotic-coated nail, gentamicin impregnated, and the defect was breached by bamboo hut technique. And this is a technique where we breach the defect as tibiotalo-calcaneal fusion or a tibiocalcaneal fusion. And how does it act? It is like use of fibular strut grafts, which are positioned at 12, 3, and 6 o'clock. At 9 o'clock, lower end of the fibula is positioned. You tie this graft together, you compress them through the nut in the nail, and this is how this technique works, has been published into Techniques in Foot and Ankle Surgery. For this particular case, after the nail was passed, a fibular stud graft 1, 2, and 3 were passed, compressed. Over and above that, orthogonal plating plus cancellous bone grafting was done. This is how the post-operative picture looked, and that ended into a happy ending. Patient is back into the action. Deformity like polio would also require this kind of fixation and fusion. Equinovarus foot with this is the kind of muscle power on a left side. And this is how she walks on a left side, equinovarus. And then the plan was open tendoachilles release, corrective tibiotalo-calcaneal fusion with the nail, and transfer of tibialis posterior to the second cuneiform to act as a sling to prevent drop of the mid and forefoot. This was the X-ray picture at the end of fusion. And this is how now she walks and focus onto the left side. She's almost got the normal gait. Deformity like adult acquired flat foot stage 4 deformity like this would require a patellar fusion assisted by the nail. A cavus deformity would also require this kind of fusion with assistance of the nail. Look, this fail of 40 who had a flail foot with pain and instability. These are the X-ray pictures. And this patient was treated with corrective tibiotalo-calcaneal fusion with a nail plus tibialis posterior transfer as a sling. Arthritis may be any kind of arthritis, but if the ankle arthritis is associated with stiff subtalar joint, then also you go in and do ankle plus subtalar fusion, which is assisted by nail, may it be RA, may it be post-traumatic with stiffness of the subtalar joint. Infection, obviously, TTC fusion with nail assistance is the way forward. A young adult who had an infection after compound injury with a very poor skin condition like this was treated with serial debridement, X-Pix, and then was finally nailed and ankle fusion was done. This is how the picture looked like. Neuropathy is a ball game where you have to use TTC nail because you need to span the joints. This was a neuropathic diabetic ankle fracture with draining sinuses after 9 surgeries when this patient was sent to us. And this patient ultimately went into nail-assisted fusion, which was augmented with the plate and limb could be salvaged. A female of 62 sustained fall in a bathroom. She presented to doctor, a diabetic lady, after 3 days, and this is how surgeon treated her. 4 weeks down the line, infection sets in, implant started giving way. Surgeon went in again and he revised the fixation. And on one fine day, this is what happened. There was a proximal fracture, and it was a case of infection, conversion of a fracture into Charcot, non-union lower third fracture. This was treated with Elizaro apparatus to stabilize the fracture, and nail-assisted ankle fusion was done. Instability like this would definitely end up in doing ankle fusion, which is assisted by nail. Avian or a giant cell tumor would also need excision of the talus, followed by the augmentation with the stirred grafts, and followed by nail-assisted fusion. So, to convey, specific indications are there for nail-assisted ankle fusion. You need to go ahead with sound preparation of both the joints, ankle as well as subtalar joint, and accurate joint position. This would be the denominator to the success. Thank you very much.
Thank you very much, sir, for discussing your lifetime experience on ankle fusion and wonderful ways to fuse the ankle with various techniques. Any questions?
So when do you prefer anterograde nail over retrograde and vice versa?
Those cases, I showed you one of the case, Ajot, where patient was a young adult and I wanted to salvage subtalar joint. And that's where I did antegrade nailing. But by and large, patients, they come in such a stage where you really may not be able to salvage subtalar joint. Even if the stiff subtalar joint is there, you want a better hold in the subtalar joint. So you go in for the retrograde nailing.
So what are the modifications that you have done in your nail design as compared to the available ones?
See, the nail which I have designed is a straight nail, and it is the only nail available in the world where you can compress ankle as well as subtalar joint through the nail. The nails which are available where for compressing subtalar joint, you have to push in thumbs over the heel. That is how it works. So it is not the nail which is helping you to give subtalar compression. So this is where in this nail, you are able to give compression with the nut inside the nail to both ankle as well as subtalar joint. I know there is an issue of whether to use straight nail or whether to use angled nail, right? I always favor a straight nail because the angled nail you need to do in a prone position or a lateral position. And mind you, these patients are quite morbid and they may not, anesthesiologists may not be comfortable nailing into a prone position. When you have a defect and you want to give compression, this all band nail, it is very, very difficult to give compression. These band nails are useful or they score over the straight nail when you have some varus or valgus into the ankle. More so varus, not the valgus. As long as you are able to bring talus underneath the tibia, it really doesn't matter. You use a straight nail or you use a band nail. In some cases where there is a gross deformity, you might have to beforehand osteotomize the medial malleolus so that you are able to shift the talus underneath the tibia and then you can use the straight nail.
Dr. Raju, very good, excellent presentation. I would like to know the method of putting the sequence of putting the screws in a straight nail as well as how you the method of how you achieve the compression.
I think you missed that slide probably. The sequence of the...
I saw the slide, but it needs a little bit repetition.
Okay. So, but I do not know. Do I again go and share this screen?
Yeah, you can share, sir. That would be fine.
Yeah.
That
Thank you for allowing me to do that.
Chandak sir, मैं आएगा?
Yeah, good morning. Welcome, Gadegone sir. Welcome. We just saw two presentations. Dr. Tanna presented first and then Rajiv Shah presented a fantastic talk on ankle fusion with the nail.
TTC nail.
TTC nail.
Can I ask a question?
Yeah, please, sir.
Okay, you, Dr. Shah, hi. You fuse a Charcot ankle. How was the patient 2 years down the line in the absence of sensation?
They do very well. As long as you make foot plantigrade, Charcot patients, they do very well. And if I am to operate any Charcot case, I tell them that the success rate is 65%. Though the success rate is to the tune of 75%, if you rigidly, strictly follow the technique and you augment your fixation. You also need to add a plate as you double the protection, double the immobilization, and double the bracing. So that's how it works. And
You
yes,
do
all those cases which do not succeed, they show their, failure very, very early. And mind you, we do not want bony fusion in Charcot. What we want is fibrous ankylosis so that we are able to maintain the foot and ankle into plantigrade position.
you do anything
Now,
to restore the sensation?
No.
you cannot restore the sensation. Neuropathy would never.
Yeah, that's
be
what I
okay.
was coming to. A lot of publications are coming because this is a multiple nerves getting compressed, especially the posterior tibial nerve and the branches of posterior tibial nerve.
Yes.
And in fact, I have done quite a few, more than 20 out of them. If the TENELS is positive, and the most of the work was done by, I think the name is Lee Dillon from Baltimore. So if you decompress multiple nerves, the sensation do come back, provided the TENEL sign is positive. In some of these, the posterior tibial, anterior tibial, lateral popliteal on the fibular neck.
So two things for that. Number one, these are still not the kind of publications which are like level 1, level 2 studies. I have tried doing the decompression of the nerves with absolute failures. And to my viewpoint, probably it would act better in any other neuropathy which is not related to diabetic neuropathy. This is what is my personal belief, level 7 evidence. But I don't now do the release of the nerve.
Okay.
And I'll really be interested if somebody is doing and somebody is really able to publish some level 1, level 2 evidence onto that.
Rajiv, sir, there is one question.
Yeah, please.
Yeah, go ahead.
Sir, in a Charcot joint, when already the soft tissues are so much devitalized, what are the chances of infection after doing the surgery in a Charcot joint?
Yeah. So you should have reasonable control of sugar. That's one thing. Number two, whenever you go in for surgery, you remove all Charcot tissues. That's the important principle. Because these are the tissues which can, give you problems, maybe further progress into the Charcot. So all the Charcot tissues which are very evident to you when you go in should be removed. Yes, chances of infection are there. They are almost double than the normal case. But this is what you need to explain to your patient. Either patient ultimately lands up into Bijlani amputation, the chances would be near 100%, or patient gets a fusion where the success rate is to the tune of 65%.
Do you need any orthosis postoperatively in Charcot joint when you get a fibrous ankylosis?
Yeah, 100%. So the first thing which is explained to the patient is that they would have to be non-weight bearing for 6 months minimum. Double the time we allow weight bearing with an ankle or routine TTC fusion. And for 1.5 years, I give them CRAW. CRAW is Charcot Restraining Orthotic Walker. So it's a AFO with an anterior cover also. So that's what is very, very important. And in a CRAW, they also mold the arch. So that's how, if patient is ready for these two things, then only you go in and venture the surgery.
Okay.
By 1.5 years, they've achieved either sound bony fusion or a very sound ankylosis, and you can ask them to leave the brace. Dr. Kotadia sir's question is about the chronology of the screws. So first two screws are the screws which are passed above the ankle.
Okay.
So you secure ankle screws, and then next screw is
Telescope.
No.
Is my slides moving and you are able to see it?
We are seeing
able
it.
to see 1, 2, 3. We are able to see.
Okay. So the first two screws are above ankle. The next screw is a transverse screw into the toes. After you pass these three screws, you push in a nut which already you have loaded in the nail and start compressing ankle with that nut. And if you have seen, this screw is into an oblong slot. And the screw below is also into an oblong screw. This is for dynamization, but this is the one which moves up and you get compression at the ankle. The next screw you pass is the screw which is a transverse screw in calcaneus.
And then you pass.
So now you have a screw into the talus, screw into the calcaneus, and then you load another nut and tight this nut. When you tighten this nut, the subtalar joint is compressed. And the last would be your posterior anterior calcaneus screw. And if you wish, you can put in optional freehand screw. Is that
Yes.
clear?
Yes. Thank you.
And the compression device rotates the nut inside the nail from plantar aspect.
Yes.
Yes, sir.
So
as you tighten, there's a screwdriver which passes through the jig, through the bolt, and when you tighten it, the screw together with together with the nut is being pushed up. That's how.
How much compression you achieved with that? How much compression you achieved with that? How millimeters? Hardly 2 or 3.
So for ankle it is like 2-3 millimeter. For subtalar joint it is 2 millimeter.
It would be equal to the transverse slot, oblong slot. That would be floating.
It gets nicely compressed. Only thing you have to be watchful that you should put your screw in such a manner that you go onto the opposite cortex with 2-3 threads remaining out. Because eventually screw slightly bends. So you must cross the opposite cortex with 1 or 2 threads out.
Okay. Thank you very much. My idea was with TTC fusion, a very early weight bearing would be a routine thing. But as you said, weight bearing almost up to 6 to 12 weeks. Is that?
6 to 8 weeks for a routine TTC. Otherwise, 12 to 16, 18 weeks for neuropathy. Even later than that.
Thank you.
Raju sir.
Go ahead, Gadegone sir. Please go ahead.
Raju sir, do you use reaming and a snugly fitting nail, or you put a loose nail inside and believe in dynamization?
That's a great question. I like to put a nail which is of at least 10 size. I aim to go at least with a 10 mm diameter of the nail. Because 9 mm diameter nail accepts 3.5 screws. 3.5 mm screws, they are not so strong. So and majority of the time, we are doing it for the neuropathic cases. So you always aim to get a bigger diameter of the nail and stronger hold where I'm going beyond isthmus. And I hardly lock the topmost screw because I want to keep it little mobile and I don't want to make it very, very, strong with a screw passed onto the top of the nail.
Thank you very much, sir.
So is there any condition where you would prefer plate and screws over nail?
So I would prefer plate and screw over nail. One, where I find that the cavity of the tibia is not so great enough to accept a nail size beyond 9. So these are the cases. Many times polio patients, many times paralyzed patients, they have a very small, narrow canal. Then secondly, there are some cases where you really feel that you want to finish it fast. I don't use the nail, because nail, you are putting a nail, you have to rim, you have to lock, and then few more things. So there I'm going with the screw and plate construct. Secondly, very, very deformed bone where pushing the nail would be difficult. Right from the calcaneus up to the tibia, I don't like to push in the nail. And patellar fusion, given a choice, I would not use the nail, because the nail occupies a 10 diameter into the talus. And you also want to put one screw which is going mesonail from calcaneus to the talus, or from the calcaneus talus to the tibia. And you also want to push in 2 or 3 talocalcaneal screws. So many of these patellar cases, I have not used nail. I have used plate and screws.
So the
Thank you, sir.
main indication for a TTC would be where the ankle as well as subtalar pathologies are there, or neuropathic foot. This would be the main.
Yes, these two would be the main. And the third in our setup, where we get a lot of post-traumatic patients. If you feel that you are not getting a good stability because the talus is already lost, or talus is like you have to sacrifice part of the talus to get the good surface apposition, you need to span beyond and you need to go into subtalar joint. And majority of the post-traumatic situation, subtalar joint is quite stiff. So it is always better to span the subtalar joint in such cases. But people initially did not, prepare the subtalar joint in neuropathic cases as well as in non-neuropathic also. So subtalar joint is the one which gives maximum problem. So that's why in my last slide I mentioned that preparation of both the joints is important. Initially, there was a notion that in a neuropathic case, you may not prepare subtalar joint. You just push in nail and come out. But that notion is now gone, because people have noticed that there is a lot of problem with the subtalar joint.
Sir,
With the
my last question.
Yeah, go ahead, sir.
Advanced tuberculosis of ankle, and there is a suspected subtalar joint also involvement. After debridement and complete thoroughly necrotized tissue is removing, is there any indication for TTC nail in such a situation?
You can go ahead and do TTC nail. You may stage it if you are not confident enough about your control of your infection. I have used screws more than the nail for tuberculosis, and they usually give good stability. And using screws for the ankle fusion or any fusion is less morbid than using a nail, because you have to put in a nail rim. You also are worried about pushing some tissues into the medullary canal of the tibia when you're using nail for tuberculosis. So either you stage it, you can do it one stage also. I have not done any TTC nailing in any of my tuberculosis patient. I've used screws only. And what I do, when I do this with the screw assistance, I push in 2 screws from the bottom, from the calcaneus, from the heel, right going up to the tibia. So like it's 120, 110, 120 screw. That also gives you good stability and acts like a TTC nail. Many times in infected situation, when I'm using screw and plate, or in any situation where I'm not using TTC nail, I remove the part of the fibula and I use fibula as a live nail. That gives me a good stability. And you see the lower end of the fibula is wide below. So when I push my fibula in as a nail, when the fibular lower end passes through the calcaneus, it gives a very good compression. And then I augment it with plate and screws. So that's what also I've used, fibula as a live nail.
Thank you very much. We also I'd seen your wonderful paper on that bamboo gut technique. That was wonderful to see that. Thank you very much. Harjot, if you have any question onto the chat box, if you are able to see.
Yes, I have seen the chat box. There are no other questions.
Okay, thank you very much. Then we move to the next.
Thank you very much.
Session.
Thank you so much.
Thank you very much, sir. May I invite now Dr. Pankaj Jindal to share his screen and speak on wrist orthodesis
Again?
Yeah, we are able to see the screen.
Yeah, okay.
Perfect.
Okay, can you see my screen?
Yeah, we'll just have
Okay,
to.
I thank Maharashtra Orthopaedic Association, Professor Chandak, for giving me this opportunity. I'll talk about wrist arthrodesis. Why you need arthrodesis? Because you need a powerful grip, and it will relieve the pain. But unfortunately, you lose the motion here. And when do you do it? The indication will be if you have an irreparable cartilage loss or you have a significant deformity. And this will either be post-traumatic, it may be degenerative, it may be inflammatory like a rheumatoid or a neoplastic condition. So specifically, it may be trauma, a malunited distal radius fracture, a rheumatoid, AVN of the lunate. It may be a tumor like a giant cell tumor of the distal radius. I'll share the examples also. A post-infective status, or you have done an implant is not working and the wrist has become painful. So other than these painful, there may be situations which are not painful, but there's significant deformity, like a spastics in a cerebral palsy, or a paralytic like in a brachial plexus, or a arthrogrypotic patient who has again a significant deformity. And these will be the patients who will require some kind of a fusion here.
Okay, your screen is not moving, and also
The screen is not moving.
Yeah. Just make it full screen and then tap on the slide and then you'll be able to move it.
Yeah, screen nahi dikh rahi.
You're able to see the screen, but it's not moving. And also make it full screen.
Okay.
Dr. Patankar has also put a chat that screen is not moving. I think stop share and share again. I think that would work.
Stop share. Okay. Stop share.
Yeah, and share again.
Yes.
No problem. Should work. Yeah, now we are able to see again.
Okay.
Yeah, this is perfect. Absolutely.
Okay. So there are options other than full fusion here. You can do a partial fusion or you can do an arthroplasty, but main discussion today is on fusion only. So you have three options, either a total fusion, a partial fusion where some motion is retained in the radio-lunar joint, or you do a replacement here. ये चल रहा है. नहीं चल रहा है. नहीं हो रहा है.
Harjot, any suggestions?
It's not moving. But it's not moving forward, no?
So you are unable to move on your PC, or you are moving, but it is not visible on Zoom.
Stop sharing.
Screen share.
जिंदल सर मुझे रख लो असिस्टेंट.
सर करना है, करके देना.
It should work. Don't worry.
नीचे वाला.
Take your own time. No problem.
Chandak sir, do you use nail or? Okay. So do you use TTC nail routinely or use screw and plate for ankle fusion?
My TTC nail use is limited only to neuropathic group. That is where I have used.
Okay, it's moving now.
Yeah, now it's moving.
Okay, so if you do a fusion, partial fusion can be between the proximal row, but motion is retained in the distal carpal row here. Or it can be just between the lunate and the radius, or it can be between the distal row, retaining the movement between the radius and the lunate here. Now, what are the options if you study the history? As long back in 47, they used a tibial strut, which was angulated here. Then in the 70s, they use a rush pin with staples here. Then they use a Steinman pin in 70s. Then they use a cross pinning here. Then use two Steinman pins to prevent the rotation here. Then they use just the staples. This was a French article here. Then they use tension band wires. They have used a trapezoidal shape of the radius, and this was reflected and fixed with screws here. They have used a locked intermedullary nail also. They have used an L-shaped plate. So multiple options have been used for stabilization of wrist here. Then came an era in 2005 of dorsal contoured plate, then dedicated plate which was narrowed when getting a hold on the metacarpal, and a wider one for the radius here. Then came the era where spider plates were used. Then external fixators. So everything has been used here. A comparison has been made whether arthrodesis is worth versus a replacement here. And it was found in this article here, which was published in Journal of Wrist Surgery. Complications are more with the replacement here, whereas of course both arthrodesis and arthroplasty improve function. They give painless wrist, and the strength is also retained here. So let's share a few clinical examples. This patient was a 14-year-old when he had fractured the distal radius. It ended up with, after 14 surgery, with a non-union of a radius and the ulna and a non-united single bone forearm. We designed an external fixator, compressed the non-union, and this was the union that was achieved between the proximal forearm bones and the carpus bone here, and went on to a union after 14 failed surgery here. We tried this patient 20 years later, and of course, the wrist is still stable here. And a person who had a 20 years, he has been told that you will never do well. He had 100% disability, went on to create chips for airlines here. A second patient with a brachial plexus injury, he had a non-dominant hand injury here, and patient was keen that his wrist should be fused in radial deviation because this hand is going to be an assisting hand. So to keep his hand as a paperweight, he wanted wrist not in neutral but in slight radial deviation, and we fixed it with a plate here. This patient had a significant flexion of the wrist here, and we opted for a wedge osteotomy and fusion of the wrist. So what we did, we removed a part of the wedge from the capitate and the lunate here, and this was fused here in this position using K wires here. So if you'll compare the wrist, which was flexed, this is now more in neutral position. If you compare the opposite other hand, you'll see the wrist is still flexed and the operated hand is in neutral then. So this went on to reasonable positioning, which was the wrist which was flexed here. A VIC patient, again 29-year-old female, we did a wedge osteotomy and removed, you'll see, appreciate the capitate which is deformed. We remove a part of the carpus bone here and brought it into wrist into an extended where it was flexed, and again using a K wires here. This was a patient who had a lunatum malacia, Kienbock's disease. Proximal row carpectomy was done, but the wrist was still painful, and therefore this was converted with an external fixator. Now this was converted with K wires. To prevent the wires from migrating out, one wire was connected to a second so that they prevented premature extrusion of the K wires here. A post-traumatic situation, painful, malunited distal radius, again K wires were used for fixation and stabilization, achieving a stable arthrodesis here. This is an interesting patient for us. A method that was used here was for the giant cell tumor of the distal radius. A part of the ulna was transposed into the center, and the plate was applied to the scaphoid, lunate, transposed ulna and the radius. So we retained the mid-carpal joint so that we can retain some movement of the mid-carpal joint here. Did it work? We took an X-ray, inflection extension. What was the position here? He had about 14 degrees of flexion, and he had about 34 degrees of extension possible at this fused wrist, which was only confined to the proximal carpus, and the mid-carpal movement was almost 30 and 40, almost 45 degrees movement here. So this is the flexion and extension in the above two photographs. and this is the flexion extension with the wrist close, and this is pronation supination occurring at the forearm. We have checked this at the position with the wrist with the elbow flex, so that it is not internal and external rotation of the shoulder, but pure pronation supination of the forearm here. This is another patient who had a fracture the metacarpal here, and this was fixed with a K wire, but unfortunately this ended up with a lot of infection in the carpus bone. So this was the status of this diabetic patient following a fracture of the metacarpal here. This had an infected draining sinus. We debrided it. The infection got under control. We retained it for a longer time. And in the end, we achieved a fibrous, painless non-union. But as long as it was painless, as long as he had a pain-free movement, as long as the fingers were mobile, we accepted this rather than going in for a formal bony fusion. So this was another catastrophic ending of the fracture of the metacarpal injury here. So this was to start with, and after debridement, they are achieving a fibrous non-union here. But there are situations where we can get something out of nothing. This was the patient who had a radiocarpal joint fusion. He had a distal radiolar joint, which was also not working. So what we did, this was already fired. This is done elsewhere. So what we did a Save Kapanji procedure here, so that some pronation supination can be achieved here at the distal radiolar joint. This is the fired joint. So we did an osteotomy here. 1 centimeter segment of the distal ulna was removed, and did it well. Yes, you'll see the amount of supination and pronation this patient could restore in a wrist which was apparently fired here. Yes, this treatment does not come without problems. There are high reoperation and complication rates, and this came in a journal as late as 2019. Patient can have persistent pain. Patient can have pain over the plate, and the plate can break. There can be CRPS, there can be non-union, there can be flexion contracture of the finger. There can be distal radial joint problem, there can be tendon rupture, carpal tunnel syndrome. So a lot of problems can still persist, but most of them are avoidable. Like flexion contracture, mobilize the finger early, non-union, put in a lot of bone graft, have a good stability here. Plate breakage, give an external support here. Chronic pain, see where else the pain is occurring. Is it at one of the carpal bones? It is at the third CMC joint. See the patient if he has carpal tunnel syndrome pre-operatively. Keep the hand elevated above heart level so that the hematoma doesn't accumulate here. Long ink screw. So see to it, this is an intraoperative problem. See to it, you put appropriate length of the screws here. Hip hematoma if you have taken a bone graft. So see to it, you have achieved appropriate hemostasis here. Metacarpal fracture, you put in one screw, remove it, again put it, and you put it multiple times, the metacarpal is bound to fracture. So these are all intraoperatively good, adherent to principles of surgery, can avoid most of these problems here. So if you see just the top line here, the problem can be non-union, problem can be infection, problem can be loosening of the implant, problem can be fracture of the metacarpal here, problem can be nerve related, especially one of the nerves getting fired here. It can be, you do a partial fusion, the problem can go from one joint to an unaffected joint to another joint here. So problem can deteriorate over a period of time. It is important patient is forewarned that if you are doing a partial fusion, it can become more deterioration over a period of time. Impingement, patient can, if you do a fusion here, that styloid process can impinge, and therefore you start with excision of the distal styloid process here, so that down the line it does not impinge here. Pain can be there, so you identify where the pain can come. It can come from DRUJ, it can come from residual union here, it can come from, especially in heavy demand patients here. Carpal tunnel syndrome is an extremely important problem which can manifest down the line. And therefore, some of the papers have recommended doing a prophylactic carpal tunnel release while you are doing a wrist fusion here. You should forewarn the patient if you are doing a partial fusion that the patient can down the line go into a total fusion here. So in summary, you do a wrist fusion when there is a cartilage damage in multiple myriad of problems like malunited fracture to infections to non-unions, or there is a severe deformity like a brachial plexus or arthrogrypotic here. There are options of partial fusion to total fusion to replacements. whatever complications are there, it's a highly rewarding operation, but complications exist and we should forewarn the patient about their existence here. I thank once again for giving me this opportunity. Thank you very much.
Thank you, Pankaj. A very good lecture giving all the varieties of fusion and the pros and cons of all fusion strategies. Thank you so much. Any questions?
So what is your best or go-to strategy, most preferred way, with plate or with fixator? Or
I'm very happy with K wires and external plaster. Majority of the slides, if you will see, were with the K wires. Of course, you require a lot of bone graft there, but bone graft with K wires with external plaster, hand elevation and finger movements. These are important to avoid problems.
and you prepare the bone surfaces by giving open incision?
Yes, I do open surgery and I prefer open debridement, remove all the cartilage. I'll rather have a shortening of a centimeter by removing just not the cartilage and the subchondral bone, but go to a healthy flat surface so that you have a good bone contact. Trying to remove less of the bone is probably going to create more problems. Losing a centimeter of length is not going to be any kind of a handicap for the patient. But you have good bone-to-bone apposition so that you can be sure that it will go on to a union.
Thank you, sir.
Your philosophy of using K-wire, the simplistic thing, is mostly because it avoids large metal frame inside and avoids complication related to plates, etc.
Probably I'll revise my strategy if my K-wires fail, but they have worked
they work very well
every time. So I don't see any reason why I should go onto a plate.
Yeah, absolutely. Thank you so much. Perfect. So K-wires also can do wonders. Minimum foothold inside, minimum metal inside, and a good result. That is what the strategy is.
I think the important thing is not just one K-wire, 2 wires, but you have to see to it once you fix it with K-wires, it is strong enough and the wires are not thin. And the trajectory of the wires, if you put in one wire, you're not happy, you put it second time, third time, and then the hole is not 1 millimeter, 2 millimeter, it will become 4 millimeter. And that's the problem. So one wire, it should go exactly where it wants to go.
Okay.
So that you don't do it again and again and make the trajectory very loose.
Perfect. Thank you so much. With this, we move on to the next talk. And may I invite Dr. Patankar sir to please share your screen and go ahead with your talk, sir.
Thank you very much.
So it's a problem.
Yeah, we are able to see your screen, sir.
You're able to see my screen. And I don't use Mac so often.
We are seeing the first slide. Absolutely. No
Yeah. At the outset, I would like to thank the Maharashtra Orthopaedic Association, Dr. ABHYANKAR and Dr. CHANDAK in particular. Or actually, I thought it's a very surprising topic to choose over all other this thing. But the theme is very good. Arthrodesis is a very important surgery, as we have seen Dr. Tanna and Dr. Shah and even Dr. Jindal. And in fact, Dr. Jindal's talk has made my job quite easy. So these cases which I've shown here are very challenging cases. They are chronic cases. The patients generally complaint or present with pain, deformity, and loss of function of the hand and wrist in particular. And by the time they present to us, they have lost a lot of money and they have lost a lot of time. So they require a certain procedure which will relieve them of all this and give them a functioning hand. So most of these patients, as Dr. Jindal has rightly said, the pain, deformity, and loss of function, we have seen very commonly in my practice. I see them mostly of rheumatoid variety. They can be either seropositive or negative. We have seen infections, either in pyogenic infection or tuberculosis. and trauma. So these are the three common presentations which present in this ghastly manner. And other varieties or other causes of problems of the wrist, which can lead to severe problems, that is deformity, pain and loss of function, can be neoplasm, cerebral palsy, post-burns, brachial plexus injuries, polios and VICs. So these are not very common and these tend to go to the subspecialties. So what is desired in all the cases? We all desire, all the patients also desire a mobile, painless, a stable wrist with no deformity, a functional hand and forearm. However, in many of the cases, out of sheer desperation or as a last solution, you have to perform a wrist arthrodesis. This is a very nice statement by Peter Stern in one of his lectures. He has said that most of the wrist range of motion is overrated. Restoration of forearm and finger range of motion following trauma is highly underrated. So he believes that most patients will accept and function reasonably well with a wrist fusion if they have satisfactory range of motion of the forearm and fingers. So what are the options? Dr. Jindal has already shown it. I'll just run through it. An intramedullary implant was used, which was later modified to an locking implant with a fixed angle like this. Cross K wires with bone graft has been described. Plate fixation, as you all know. Modified Gill's technique, this was also shown by Dr. Jindal. And this is arthroscopic assisted screw fixation, external fixation. So all these techniques have been described in literature. However, all these techniques, as Dr. Jindal has presented a very long list of complications, I feel that all these procedures are quite complex and they are fraught with a lot of complications. So I would like to present my way of doing this wrist arthrodesis, which is actually inspired by these two techniques. One is this intramedullary nail, and by putting these nails from the side on the third and second metacarpals. So obviously, in all these cases, you have to take a dorsal incision. Most of the times we have to take a dorsal incision. You have to debride and erase the cartilage because otherwise fusion is not possible. In most of the cases, in fact, I recommend that distal ulna should be excised because we are, since we are looking at a stiff wrist, we want to have a normal working forearm with a painless forearm rotation. So we excise the distal ulna. Direct procedure is the commonest what we can do. Sometimes, as Dr. Jindal has said, we can also do a segmental resection. You reposition the wrist in the proper axis, and then I don't like to use anything stronger or anything bigger than a 2 millimeter wire because I like to keep these wires flexible and I like to keep the control of these wires in my hand. So the entry of these wires as we start, either 1.5 or 2 millimeter wires, depending on the shape and size of the forearm and the hand, you start the entry at the base of the second and third metacarpals like this. One is from the lateral side, one is from the medial side. And then I remember that these are thin wires, these are flexible wires. They are passed through the carpus. There is no reason to use a drill, power drill. We can pass it with a T-handle. The wires are sharp, they are trocar pointed wires, and they are passed through the carpus. Once the wires come at this place, then obviously, if they go further, then they will cross the cortex, they will cross the metaphysis. But in most of these cases, the distal radius is either fractured, there is a rheumatoid element there. So the metaphyseal bone is very thin, and this is not likely to give a good support in spite of additional plaster. So what I do is I bring out the wires at the level of the carpus by flexing the wrist and then bend them in the curved manner as if you are doing a radius nailing. So you bend them or a bouquet technique or a ender's nailing. So you bend them at the radiocarpal joint so that they can be inserted intramedullary after going through the carpus from the base of the second and third metacarpal. So this is how the wrist is flexed, the wire is bent, and then the wires are inserted from the second and third metacarpals, giving a sort of 3-point fixation in the shaft. A standard 6 inches wires are enough. Occasionally, you can go for 8 inches or 9 inches wires. And this is the construct that is seen. These are taken on bone models. So So that is how I do it. And this is what it is seen on the X-rays eventually. Now, what is most important? Obviously, now the wrist is positioned well. The wrist is, as you can see, positioned in about 5 degrees of ulnar deviation. The ulna is excised, and the wrist is, you can see that there is a minimal extension, about 10 to 15 degrees. Now, how do we achieve this? We cannot obviously put the wire in this bent fashion when you are inserting it through the carpus. So at this time, what we require is, once the wire has gone like this, it is passed intramedullary, you place the wire completely as much as possible into the radius shaft, distal shaft, and then the wrist is manipulated with the wires in C2, both the wires in C2, into the desired position of extension for your particular case. And then this is the final construct. The wires seen in the AP view like this, and the wires seen in the lateral view. This is about 5 degrees of ulnar deviation, and this is 10 to 15 degrees of wrist extension. The wires are either cut flush with the bone if you don't desire to remove the patient wires, or you can cut and slightly bend them, but you have to bend them in as an umbrella hook or completely like a rush nail, so that they don't hurt the soft tissues. They don't cause any painful conditions by which the patient is not going to cooperate in the future. The wound is sutured. I always apply a volar and dorsal slab and keep it. I tell or counsel the patient that the slab or plaster support may be required for about 3 months, because we intend to have a solid fusion. We can accept a firm fibrous ankylosis, but a solid fusion is desirable. Now, this is a case of a seronegative rheumatoid arthritis, a rheumatoid variant it was, in a young boy. So he had a deformed wrist, a weak grip. You can see the fingers are working well, but weak grip was weak. There is a deformity, and he was having a lot of pain because the carpus was not positioned, and he has no supination of the forearm. And that is how we do it. So I excised the ulna, curate or debrided the wrist, excised the proximal row here, and that is how the wrist extension was achieved. And that is the function. That you can see the function of the forearm and function of the hand is retained, and it is painless. Another case of again a rheumatoid variant. Again, you can see in this wires passed from the second and third metacarpal base. 6 inches wires are enough, and that is the construct, and that is the function. Another case, you can see that here there is a lot of arthritic element in this radioulnar joint. Also, the wrist joint is also disorganized. You can see a very nice angulation of the wrist, and that's the arthrodesis which is completely healed. This patient had initial symptoms of adventitious bursitis, probably because these hooks were, these wires were slightly proud, but then eventually it settled down, and patient did not have any flex or extensor tendon problems. So we decided not to remove the wires, and that's the function of the patient. Now, this was a case of a tuberculosis of the wrist. And after taking all the reports and waiting for about, we waited for about 4 to 6 weeks for the start of the therapy, AKT, and we gave some antibiotics also. You can see that there is a swelling on, there is a lot of swelling on the front and back of the wrist with a lot of synovitis. So ultimately, we opened the wrist on the front and back, debrided it, did a thorough synovectomy here, and then a wrist fusion was done at the same time using these wires. And that's the function of the wrist at the end of the about 2 months. Now, this was a case of a polio of the hand, in which an arthrodesis was attempted elsewhere. You can see the previous scar and all that. And somehow it landed up in a very grotesque deformity with no function. You can see that the thumb is not working. Now, arthrodesis of the wrist, especially in polio, CP, brachial plexus, and all these cases, not only gives you a good stable wrist in a proper position, but also gives you a scope for harvesting tendons of the wrist, the original wrist, for transfer. So in this case, the thumb was not working. The fingers also were not working. So I used the opportunity to correct the deformity and put the wires and also harvest the tendons for transfer, so that you can see that the thumb has started working now and his fingers have started working, and he's has a useful hand. I'm not saying a normal hand, but he has got a very useful hand now. Now, these are not very commonly seen nowadays with a lot of conferences, and everybody is now aware of the trauma and proper treatment. But however, we still get these cases in Mofussil towns and who come from towns who have not been treated properly or who have neglected themselves. And this was a case of a severe post-traumatic arthritis of the wrist following a distal radius fracture. So in this case also, the lot of pain and stiffness of the wrist was treated by debridement and correction of the deformity here, and stabilizing the wrist with a multiple K wires here. And that's the function of this hand. Now another case, he also presented about 6 months. He did not take any treatment. I don't know for what reason, but he came at the end of 6 months with this grotesque deformity of the hand and forearm. And that was you had a stiff fingers, stiff MP joints. And so initially I opened it on the volar side and did a thorough flexor tenolysis. I did a median neurolysis also. And through the volar aspect only, I shortened the radius and then got the radius in position and then inserted the wires from the dorsum like this. And of course, we have to, with these chronic cases of trauma, we have to use splints to start regaining the hand function. That was the arthrodesis which went on to heal well. Obviously, it is healed with the bone in slight dorsiflexion here, but that's okay compared to the previous picture which he had presented. So he has a very reasonable hand function with good forearm pronation supination. Now, this was a 85-year-old doctor whose son also was a general surgeon, a senior surgeon here. And he was treated initially with a close reduction in a plaster, distal radius fracture. But eventually, because of medical problems, they could not do they could not put in a pin and they could not give him anesthesia. So he landed up 1.5 months later with a severe deformity and stiffness of the wrist and hand. You can see that the hand is absolutely non-functional and the wrist is very stiff. He has a lot of pain. He still had medical problems. So we got that under control, and giving a regional anesthesia, I excised the distal radius and inserted 2 K wires after correcting the deformity into the radius. And that is, you can see that the whole hand function has been restored and the hand splints have been given to strengthen the forearm and hand. And that is a follow-up at 3 years post-op. The patient actually came for some discoloration of the skin unrelated to the original problem, but he came to me for follow-up only because of this. Otherwise, actually medically unfit. So you are not coming for follow-up also. So that we got the follow-up because of this skin problem. So that you can see a very good function of the hand following wrist arthrodesis. So wrist arthrodesis eliminates pain in the wrist. It provides stability. It corrects the deformity. And in cases of neurological problems, it gives us good tendons for transfer. The problems of wrist arthrodesis in general is that most patients can perform activities of daily living, but some tasks require functional adaptation, especially perineal care can be difficult and use of wrist in tight space can be difficult. These are some papers which highlight the impact of the wrist arthrodesis, and the perceived disability from reduced wrist motion is greater than objectively measured functional loss. And Hastings also has mentioned that functional evaluation, the majority of the wrist arthrodesis patient can perform majority of tasks, but requires modification or adaptation. And about 70% in their paper return to their original occupation. So this statement of Peterston, I think, is very important. And one should remember it, that wrist is not everything. hand and forearm is also very important, or quite, I think, more important in especially in cases where the wrist is affected. And the advantages of this technique, this simple insertion of 2 K wires in a, I would say, in a flexible manner, in a curved manner, is that it's a very simple technique. The K wires are easily available, low-cost implants. The technique provides very good stability. I have not seen any tendon adhesions. I have not encountered any skin problem. And you can really use it in all cases of wrist problems which require arthrodesis. Probably adventitious bursitis we have seen in some cases, but can be managed by just simply removing the nail after the job has been done. So our aim is we have achieved a painless, stable wrist with no deformity, a functional hand and forearm with this technique. I thank you all for your attention.
Thank you very much, Patankar sir, for showing a unique technique. And as you have emphasized, the most important thing you have achieved is a good wrist function, a good forearm rotation with a fused wrist with this unique technique. Any questions to Patankar sir?
So the entry point is at the base of second and third metacarpals.
Yes.
They are made with a thicker K wire.
No, they are made with the same K wire. If you use a thicker wire, there is a possibility that the whole thing may just it become loose. So there is no reason to use this thing.
Then while making entry, before making entry only, it is bent already, or
no. It is inserted straight, as I've shown in the presentation in the multiple examples or demonstrations. So I cannot. Sorry, I cannot see. Yeah, can I go back here again? Yeah, you can see this. Can you see my screen?
Yeah. Yes, we can see your screen.
Sorry.
Patankar sir.
Yes.
You have prepared a very nice loop over the wrist in the lower end radius. So it is always the same which you see, because you have shown number of it requires a very precision and bending of the wires.
Sir,
So,
can I interrupt you? This is what Dr. Harjot was asking. So suppose you, in fact, it is very difficult to insert because the carpus and the distal proximal metacarpal shaft or proximal metacarpal is all one solid bone. You cannot insert curved wires through this. The wires will not go into your desired position. So what you need is that you take the wire here, the same wire like this. You take this wire and you go up to the radius or up to the wrist joint. And once you come here, you bend this wire. And then you just push it inside. Because if you go straight, you will go outside, as I've shown here. So when you curve this wire, it goes as if you are doing a radius nailing.
Yeah, got the point, sir.
Yes.
Yeah, got the point.
Yes, got it. And since they are flexible, they may be taking the shape of the going along with the
shape of the radius. Yes.
So these are straight up to the carpus bone, and then they are bent in the radius.
Yeah, they are bent once you come to the wrist.
Yes. So they are having a firm grip initially up to carpus, and then a flexible grip inside the radius bone.
Yes.
A very, very novel concept indeed.
Yeah.
So thank you very much with this.
putting wires, then you give a desired extension of the wrist.
Yeah, by just pushing the wrist with the wires in, just give it a push from the volar aspect, and you can get the wire, because they are thin wires, you can bend them.
Yes.
Do you feel anytime the wires gets broken in between because of bending and anything?
No, sir, they are bent only once. So you don't bend them off, because if you bend them on and off or keep on bending them and or keep on changing the angle, then they'll bend. But anyway, you have to do it only once. I have not seen any bending either during the operation or even post-operatively.
With this, I am sharing the screen of Dr. Sampat Dumbre Patil and sharing his presentation. I hope you are able to see the.
Good morning. I'm going to talk about tibiotalar arthrodesis, that is ankle arthrodesis done with screws and plates. Any arthrodesis success lies in the approach, that is good exposure approach, which will give you opportunity to nicely prepare the joint and then put the joint in good position. And of course, then the fixation. So we do not directly jump onto fixation, but as any other joint, we do consider these 4 things. Now, in ankle, that is tibiotalar joint, approaches can be anterior, medial, lateral is transfibular, or any of the combination. Here, in this case, anterior approach is taken, and apart from this is the leg, this is foot, this is medial aspect and lateral aspect. You get adequate exposure. Anterior exposure is adequate to visualize both the gutters and the tibiotalar joint. But key is to keep the sheath, if possible, intact of tibialis anterior, because otherwise it will keep the pressure of tibialis anterior tendon will cause some issues in wound healing. So this is a tip. This is a case of ankle arthritis where anterior approach was taken and 2 medial screws, 1 lateral screw was used. Another case, neglected trauma with significant deformity. Here, both medial and lateral approaches were needed because this is a lateral transfibular approach, medial approach, because you need to correct the deformity. So in order to achieve good exposure, both approaches were taken, prepared the joint, and it was non-neuropathic, so only screws were used and it went on to heal well. Now, once you get a good exposure, you need to prepare the joint surfaces well. Like in this case, it was an arthritis of ankle joint. Now, to prepare a joint, you have to spend good amount of time. A lot of patience is needed in preparing the joint adequately. You can take a sharp cut with the saw, or you can prepare the joint with curate and prepare it according to its own shape. Advantage of saw is it is easy, but then when you take this saw cut, you are committing for the position of joint. Suppose you take it too oblique, then you may place it in little plantar flexion or dorsiflexion. But preparing the joint according to its own shape will give you flexibility to keep the joint in position which you want. So in this case, you have done it according to the shape of the joint, both tibia and talus, and see the adequacy of preparation. Usually the posterior part is not adequately prepared. So you have to reach there and see that joint is adequately prepared and then fixed. This is how it was fixed with the screws. Most important is position of joint. We know that ankle should be in neutral position of dorsiflexion, plantar flexion. It should be in neutral position. 5 degree of valgus and external rotation, avoid internal rotation. And always it is important that talus should be taken back. It should not lie anteriorly in the tibial. It should lie at the level of tibial plafond. You avoid anterior subluxation of talus. See this. Now, initially we were taught that, okay, you can accept little plantar flexion and you can build up in your shoe. Yes, you can do that, but patient, they do not like it functionally. See this. Here, some amount of plantar flexion is left, but patient, they don't love that plantar flexion while walking. And I will show you, this is another, this is not the exact same patient, but see some equinus is left here and see how she walks. Now she walks it cleverly considering her equinus. She always keeps the right foot in front of left foot. She never completes the cycle completely like this. She doesn't cross it the other way. So equinus gives issue unless you build up in some footwear. Then fixation. Here is a case of again, neglected trauma, 6 months old trauma. And here, here we have fixed syndesmosis joint as well, along with the tibiotalar joint with the screws. So this is also possible. Some kind of arrangement of the screws is known, like 2 medial, 1 lateral, or 1 medial, 1 lateral. But in this case, even syndesmosis is fixed with tibiotalar joint. And this is how he went on to heal. She's a lady where there was a non-healing ulcer because of varus deformity. We corrected it in ankle with anterior approach, and only 2 screws were used, and it went on to heal well. Sometimes if you are confident that the joint deformity correction is not much, you can do orthoscopic ankle fusion, also tibiotalar fusion. And see this in this lady, we did orthoscopic ankle fusion, and we used screws, 2 medial, 1 lateral, and see this. This is how it went on to heal well. But the position is important. Talus should be sucked in. It should be at the level of the plafond of the tibia. We avoid talus subluxating anteriorly. Now, you can improve their gait. Same lady walking like this. Of course, stiffness is there. Now see, this gait can be improved by giving footwear with rocker bottom. If you give rocker bottom, then the gait will improve. See, same lady, but see the gait. Now rocker bottom, you give rocker to the sole, and see their energy improves, their gait cycle improves. So after ankle fusion, it is wise decision to give the rocker bottom shoes. Another case of ankle arthritis, and here, along with these screws, anterior plates are chosen. Obviously, anterior plates are going to increase the rigidity of fixation, and this I am talking about. When you are placing the screws, this wire is important. I don't know whether you are able to see this wire. Now, this wire goes from lateral side, and it starts from this lateral process of talus, and then we take it out medially up. This avoids the penetration of screw in the subtalar joint, like this. So this avoids the screw penetrating in the joint because you are already starting on lateral side. So this is a tip that you start on this side, and then one wire from lateral to medial, but superior to inferior, lateral to medial, but inferior to superior, and you can take it out from here, and then you can insert the screw from superior to inferior both sides, whatever you like. But this is the trick to avoid penetration into the subtalar joint. And then such plate was put anteriorly. Obviously, this anterior plate is going to increase the rigidity. Now, how it helps? Anterior plate is a tension band resisting implant for plantar flexion. Buttress resisting in dorsiflexion, and it is a neutralization plate for torsional movement. So it is going to add to the stability of the construct. In fact, this paper from Foot and Ankle International 2013 talks about 2 plates. They are better than a single plate. Of course, they are anatomically designed plates, lateral and medial, and this is the literature evidence. In our case, this is a calcaneal deformity case, hardly any calcaneum left. Some soft tissue transfer posterior, tendon transfer posterior was done, but was not helping. We opted for this anterior approach, preparation of the joint, tibiotalar joint, some wires, and we used this distal radius plate anteriorly and 2 screws and achieved a nice fusion. And see this good plantigrade foot now, and look at the gait. Again, we have given rocker bottom shoe for her. A few examples, actually, they are not tibiotalar fusions, they are actually TTC fusions, but I'm just going to show how different plates can be used in this case. This was a neuropathic joint, and to increase the rigidity of fixation, you may have to sometimes include subtalar joint, like in this neuropathic joint. and adequate preparation of the joint and reduction of the joint was done. Fibula was inserted intramedullary, and then this plate was applied from lateral aspect like this. This went on to heal. Another case of trauma and failed fixation was there. Again, distal tibia anterolateral plate was used in this case. Again, it is a tibiotalar. It is not a tibiotalar fusion. It's a TTC fusion. But I'm just going to show you how to increase the rigidity in some cases when it is needed. I just came across an interesting paper from Foot and Ankle International where they talk about screws used in tension band principle, like a Chanley fixator. So 2 screws in talus, 1 screw in tibia, and then from both sides they have compressed with wiring, tension band wiring. So this is interesting paper I got. I have not done it in my practice. Another case from the literature, this is not my case, where the fixed angle blade plate was used from posterior aspect in a difficult pilon situation. Just to show that how adjacent joints play a role. So try to not violate deep joints like subtalar joint or talonavicular joint. I'm just going to show you an example where a very sound TTC fusion is obtained. So tibiotalar is gone, subtalar is gone, but talonavicular is intact and very sound fusion. But look at this lady. She has this much of movement, and this movement is at talonavicular joint. This much dorsiflexion and plantar flexion movements about 10 degree. They are there in talonavicular, that is midfoot, and they are helpful for the patient in moving. To summarize, success of any joint or tibiotalar, even ankle joint fusion lies in the approach, that is adequate exposure, so adequate preparation of the joint, good or ideal joint position, and then fixation with the screws on plate. Plate is definitely going to add to the rigidity of the construct. Thank you so much.
We must thank Dr. Sampat Dumbre for this excellent lecture. With this, we invite Dr. Gadegone sir to present his work on resection orthodesis of knee. He has a vast experience on this topic. He will be presenting an interesting series of patients. Welcome, Dr. Gadegone sir.
Sir, good morning.
Yes,
Sir, am I visible?
yeah, you are visible. Your voice is very clear, and we can see your presentation.
Okay.
And love to see your good cases.
So, this is for benign tumor treatment. As you know, all extended curettage, use of power bar, phenol, liquid nitrogen, cement, and other methods reduces the recurrence. For an aggressive tumor, wide resection may be recommended treatment to prevent recurrence. In modern era, use of allograft and megaprosthesis have become the method of choice after bone tumor resection at the knee joint. And endoprosthesis provides immediate stability and mobility to the knee joint, but it is costly and limited longevity. An imported modular endoprosthesis for the knee cost about $9,500. So high quality indigenous implants are not yet available at the affordable prices. Allografts are not easily available. So modern facilities or expertise may not be really available. The surgeon has to rely on other technique of treatment, such as non-vascularized fibular stud graft, graft, and turnoplasty for the fusion of the knee after resection. The aim of presentation is to identify the effectiveness of en-bloc resection and biological reconstruction by autograft in the tumor around the knee. Arthrodesis provides a reliable means of treating such condition. Two methods: root stud fibular grafting after excision, and another method is a femoral or a tibial turnoplasty with adjuvant a IM nail or plate plus corticocancellous grafts. The after wide resection, two struts were fashioned from the harvested fibula. Fibulae inserted into the medullary canal at the resected ends of the tibia and femur. The knee was orthodised in 5 to 10 degree of flexion. Limb kept 1 centimeter short for clearance and plate or nail intramedullary nail fixation. This is one of the example. Aggressive distal femoral tumor, resection arthrodesis planned. The knee was orthodised in 5 to 10 degree of flexion and 1 centimeter short, and cancellous bone grafts were placed transversely along the strut circumferential over the host graft junction and intramedullary rod fixation. This is how you can see. These are the 2 strut grafts, intramedullary nail, and fixation of the fibula as well. So this is how it is. The examples: a Versailles 20 years female, distal femoral giant cell tumor, treated by curettage and cement implantation, presented with a large swelling around the knee and inability to walk after 3 years. Biopsy showed aggressive giant cell tumor and there is a recurrence. So what to do? A planned resection arthrodesis, en masse resection, and the defect is filled with the 2 strut graft fashioned from the harvested fibula. Fibulae inserted inside the medullary canal at the resected end of the tibia and femur with IM nail. So it is not inside, but it is the side of the canal. We have to prepare the tunnel like this so that it fits well. This is a 12-month follow-up. This is a 2 years follow-up. And incorporation of the cancellous graft and the hypertrophy of the fibula, 3 years follow-up, 5 years follow-up, and you can see more than 15 years of follow-up, hypertrophy, complete incorporation, a stable limb. She is able to do all her activities except flexion of the knee. And this was before her marriage. I did the surgery, and this is the yesterday's picture of that lady. Another example, a 30 years old lady, questionable giant cell tumor because of the morphology, this configuration of the X-ray, and then large swelling. You can see here, en masse resection was done again, intramedullary rod, fibular grafts, and you can see here, these are the same procedure used, cerclage wire to keep both the grafts together, and all corticocancellous graft. Fibula, this patil is also used for the graft at the femoral junction, and you can see a tibial junction, and you can see complete incorporation of the fibular graft. 1 year follow-up, 3 years follow-up, and you can see 5 years follow-up, and she is doing well. Probably now, this is 10 years ago. I am trying to contact her, and probably I will get a new X-ray after 10 years of follow-up. Another example, a giant cell tumor in a 30-year-old lady after curettage and cement with the distal femoral fracture. You can see here, this was done somewhere else. And ultimately, you can see there is a osteolysis, recurrence, loosening of this cement, and this is a tumor and curettage. So I removed the plate, and then ultimately same procedure was done after en masse excision and corticocancellous graft at the resected ends, tibia and femur with IM nail fixed, 1 year follow-up, and you can see more than 10 years of follow-up, complete incorporation and hypertrophy of fibular graft. She is a lady from Ballarsha, married in Azamgarh, and she always tries to contact me that she is well. So you can see here how a stable limb, and you can see there is a hypertrophy because of the stress effect of the nail and screw, but she is happy, and you can see this fracture of the distal femur has also healed and without any problem. Another example, I did this surgery in 1994. He was not willing for amputation, therefore you can see a large swelling, and this is how still the resection arthrodesis, and 9 years of follow-up. There was some breakage of the nail. I given a plaster. He did not turn up again. And then 9 years follow-up. This is the X-ray. He was walking, died of pulmonary metastasis in 2007. So turnoplasty, another method of doing a surgery, excision of tumor in upper end of the tibia, required length of the lower end of the femur slipped into the two halls, and one hall above it is turned upside down and fixed over with the left stump. Cancellous bone graft were placed transversely along the struts and circumferentially over the bone graft junction, IM nail and plate adjoint. And you can see this is a giant cell tumor of Mr. Gaware, 56 years old, and this was done. Articular margin were not very much in view. It was done near about 20 years ago, and you can see here after a en-bloc excision reconstruction is done, a turnoplasty technique, and you can see here 1 year follow-up. He was walking well, and then he died in an accident. He was from a Chamorsi, a Gadchiroli district. Another example, a aggressive giant cell tumor, 46-year male, everything is gone. And then you can see here what I did after an en-bloc excision reconstruction is done by turnoplasty technique. You can see half of the lower end of the femur. This was transferred to the tibia. Actually, it is through the tibia, and whole the area is filled up with the corticocancellous graft, and nailing was done. This is a 3 years follow-up. And you can see after 5 years of follow-up, he had a fall, and then there was a motor vehicle accident fracture at the nail side. Then again, how to repair it, because there was a fracture of the nail as well as the fracture. He was walking very well, and ultimately exchange nail, plate and augmentation with bone grafting was done 1 year ago. And you can see here the patient is doing very well. Another example, a resection arthrodesis using autograft screw fixation and X-fix. This was the X-ray, turnoplasty was done, and you can see there are the post-operative X-ray are not available, but you can see a resection arthrodesis using autograft, 20 years follow-up. He is doing all activities, but unfortunately fall from height and fracture at this host junction of the femur and tibia. And you can see here, this is the turnoplasty, and ultimately a double plate fixation with by revised last 6 months. And you can see this is the X-ray, and now this is the functional outcome of this patient. Video is not working, but you can see here he is walking and doing all his activities without any problem. Another example, a lateral tibial condylar fracture, 32-year female, MRI demonstrate extension into the articular surface, complete excision, turnoplasty, part of the femur, not half part of the femur is transferred. And you can see this is the 5 years picture and more than 15 years of follow-up. She died of coronavirus. Last year I telephoned yesterday, and there was a bad news. So these are the 15 years follow-up of the same case, plate, turnoplasty, and bone grafting. Another example, a lytic lesion in medial condyle of the tibia turned out to be a giant cell tumor. That time, probably 40 years ago, resection, compression arthrodesis of the knee. You can see here, this is the half of the femur is removed completely. 20 years follow-up. This is 1 year, 20 years follow-up. And now she is 40 years old lady. Again, she had a fracture of the distal femur through the arthrodiscum. And this is revised with nail and bone grafting. You can see here it's how it is difficult to do a nailing in the structure. This is she is doing well. I yesterday telephoned her. She is out of town, and probably she will share the X-ray tomorrow. So the average length of the fibula strut is 7 centimeter, the longest being the 14 centimeter and the shortest being 5 centimeter long. The average defect length was 8.5 centimeter. Additional fixation with external fixation, plate fixation, and IM nail. fibular bone grafting, there are some donor morbidity because you have to remove the whole of the fibula, keeping only a 5 centimeter proximally and distally. Moderate gait changes, treatment, and you regain the length of the, you regain the strength of the peroneal, FHL contracture, and peroneal paresthesias are known after extensive removal. So validity of the lock nail, it gives a prolonged support and maintain continuity of the bone. It is one-time method, technically easy, and coverage of the implant is never a problem. Biomechanically, the plate and implant plate is an implant which is inferior to the intermediate nail, being some in the away from the line of the load, and you can see here nailing gives a better result than the plate. So in endoprosthesis, patient who reduced an arthrodesis had a more stable limb and performed the most demanding physical work, but they had a difficulty in sitting. However, endoprosthetic patient have to live a more sedentary life due to the feeling of weakness and instability, and you may get a loosening. That is the only disadvantage. The patient is unable to sit and bend the limb. So approximately metastasis is near about 3% that we have to tell to the patient. So follow-up of a 13 patient of a tumor around knee with this sternoplasty and 2 fibular subgraft, more than 10 years of my follow-ups, probably 1 or 2 cases, they are more than 25 years. 2 patients had a transient peroneal palsy which has recovered. 2 patients developed inflammation, required some plastic cover in 1 patient. Refracture in 3 cases revised, and 2 patients died. 1 patient had a local recurrence and metastasis, and other cause is not known. So resection arthrodesis of the knee was well accepted by our rural patient. Resection arthrodesis achieves external stability, but has a major drawback of lack of knee motion. In conclusion, the procedure of resection arthrodesis of the knee using a large autograft with a long intramedullary nail provides patient with a stable, durable biological reconstruction that allows early weight bearing, and the procedure carries low incidence of infection. And if at all it fails, revision surgery can be done without sacrificing the limb. Thank you very much.
Thank you, Gadegone sir, for showing a large series of resection, orthodesis, and turnoplasty. It was your long experience on these tumors, which probably in the newer light of things in giant cell tumor, we'll be doing more of extended curetages and joint preservation surgeries. Thank you very much for in that era. We go into an era where these techniques were not available, and you had nicely done resection, orthodesis, and turnoplasty. May I ask you how much amount of blood transfusion usually is needed for all these cases?
At least 3 bottles of blood, at least 3 bottles.
So we have to be prepared with that amount of transfusion. Any questions to Gadegone sir?
So with this note, we can end the session.
Yes.
Excellent presentation, Gadegone. Good cases.
Very
With
good.
long follow-up.
Yeah. So
Kiran Saoji sir has sent his appreciation for the webinar on YouTube chat. Sir.
Yeah, I have noted that, Dr. Kiran Saoji. So Harjot, we saw a very good deliberation on knee orthodesis from Tanna sir initially, then an ankle, 2 different techniques, and Rajiv Shah sir showed very good cases of nail fusions, TTT fusion. Then we had Dr. Sampat Dumbre Patil showing very good plate fusions. And we had a wonderful presentation from Pankaj, Jindal, and Dr. Patankar on wrist orthodesis. And we realized the usefulness of a simple K-wire for achieving fusion, a simple and elegant techniques from both these stalwarts. And Dr. Gadegone showed a very good large series of extensive resections and orthodesis. So that was wonderful. If there are any questions from faculty members, most welcome. We had a wonderful webinar, and thank you, Dr. Kothadia, for giving us this opportunity. Thanks, Harjot, for moderating so well and coordinating all the things and creating a wonderful brochure for the webinar. We really enjoyed the presentations. We really enjoyed the various inputs. And that would be really interesting to all the delegates who either have watched today or in future. And nicely we are able to see now Dr. Kothadia in person.
I was Mr. India for that time. Now
Yes.
again I'm back.
Yeah.
So thanks Dr. Chandak and all the faculties for such a fantastic webinar.
Yeah.
And everybody has contributed to the excellent academics in this, put a lot of cases. So sincerely thanks for Chandak and Ajart for conducting this session very nicely.
Any final comments, Patankar sir?
Timely finishing the webinar.
Yes.
Yeah.
Final comments from Patankar sir?
No, it was a nice, I would say, revision for me for the knee and ankle this thing.
Yes.
For an idea by Dr. Dumbre Patil regarding that rocker bottom thing is quite useful. So I don't see these cases now anymore. But the idea of a rocker bottom, I would say, addition to the footwear is quite interesting.
Yeah, we'll have to see that because that was a very good input.
Yeah, that was a good idea.
Rocker bottom, that gait would improve a lot.
Yeah, definitely it would improve. Yes.
Next patient, I'll be looking forward to such a patient where we would advise a rocker bottom to the patient and see the gait, how it transforms. So small ideas definitely give us a large input. And on that note, we would be ending this webinar. Thank you so much. And over to Kothadia sir. Your idea of getting a webinar on orthodesis, that was great.
That is excellent webinar. This is a totally different topic, which is not a routine topic, but it is very important. When everything fails, you have to come to some salvage procedure where the orthodesis becomes a very good salvage procedure in the joints like knee, wrist, ankle, and the patient is back to their almost near normality. So it was an excellent idea of Dr. Chandak, who has floated this idea to have a webinar on a different topic rather than trauma and other things. It was very good. All the faculties, they contributed very nice ideas, and there were a lot of inputs and there was a lot of discussion among the faculties, as well as there are a lot of questions from the viewers also. So I sincerely thank everyone, also Harjot and Chandak and all the faculties for such an excellent seminar on this orthodesis. Thanks a lot, everyone.
Thank you and good day, sir.
Harjot, what is your take home from this webinar?
I enjoyed a lot because this was the topic. Being a young surgeon, I have not seen many arthrodesis except for ankle. Knee, I have never ever seen. Wrist also, I have never ever seen. So with K-wires, it is very easy also. And I only imagine that plates are the only go-to surgeries. Even ankle techniques, both Dr. Rajiv Shah sir and Dr. Patil sir demonstrated very nicely.
Yes, and same feeling. I hope this feelings would be echoed by many young surgeons who would be attempting to do orthodesis. Everyone would be required to do sometime in their life orthodesis for infections and various disabling conditions. And orthodesis is an operation, possibly a final solution to their perplexing problems of loss of function and grotesque deformity, but it puts life back on wheels. They get back to their job, they get back to their work, and these patients are ever grateful to us. Once we do a successful orthodesis, these patients are lifelong patients. They would keep on turning again and again with new patients or their minor problems. And since this limb is long, they occasionally develop some new fractures because of the long strain pattern on a fused limb, and we get an opportunity to see them back again in life. Thank you so much. On that note, we would thank all the faculty members. And thank you, OrthoTV, for beaming this webinar. Thanks, everyone. And we would ask them to close down this webinar. Thank you so much. It was a pleasure listening to everyone. Thank you so much.
Thank you. Thank you. Good day, sir.
We can stop streaming now.